هل السكرين لسه واضح عندكم؟
لا راحت.
اوكي go back. رجعت السكرين ولا لسه؟
يس رجعت.
So our objectives from this lecture is to know the difference between fractures, dislocations, and sprains, to know the signs of fractures and dislocations, and to be familiar with types of fractures, and how to describe fractures, principle of fracture management, and open fractures management. So simply, when the injured bone or broken bone, we call it fracture. If the joint, two sides of the joint separated, we call it dislocation. If the ligament injured, we call it sprain. And if the muscle injured, we call it strains, and ruptured tendon in case of the tendon injury. So the definition of fracture is a disruption or break in the continuity of the structure of the bone. And we see here like different types of injury to the femur fracture. So the diagnosis is a femur fracture. Do you think it's enough to say femur fracture? You need to mention what's the side of the fracture, right, left, the location of the fracture at the femur. Is it mid-shaft, proximal, distal? Is it comminuted? Is it non-comminuted, transverse, oblique? So all of these information should be mentioned during mentioning or reading your X-ray, or like in communication with the other surgeon or other colleague. So again, why we classify this fracture? The classification is to speak a common language with other surgeons, and also it's a treatment guide. So whenever you hear comminuted fracture or open fracture, it means that patient he will go for surgery, or patient he will be conservative from the name of the fracture or even location of the fracture. And also it's a comparison, so you know the diagnosis and you know the prognosis and outcome of the fracture from the classification that mentioned during like convey the message to the colleague or even to write the diagnosis. So in order to classify fractures, you need to know skeletal anatomy. So it's important to know what's the name of the bone and what side and which location in the bone. Is it proximal epiphysis? It's distal end of the fracture or the bone? It's metaphyseal part, diaphyseal part? It's at the neck or at the joint? So it's important to mention the location and the anatomical location of the injury itself. In the pediatric, as a special group, also you need to know where is the epiphysis, epiphyseal plate, and the metaphysis and the diaphysis. So it's a bit different from the adult. In order to know the fracture, of course, our method of choice to investigate about fracture is the X-ray. So how can you order X-ray? X-ray in general, you need, there are rule of two. So you need to check at least two views, the anteroposterior view and lateral view. Okay, and you need to see two joints, the joint above and joint down. Like tibia, you need to see the knee joint and you need to see the ankle joint. Also, sometimes you need to order two times. So the first time on presentation before you do any manipulation or do reduction, and the second time after reduction. And also two sides. Sometime in pediatric, we need to order right and left X-ray of the affected part of the bone due to the multiple phases, different anatomy, and in this situation, it's helpful to look to the other side to find out if there is a fracture. There are special views like oblique view. in case of evaluating some different joints or bone, and also X-ray. In added to X-ray, you might need CT scan or MRI. So in general, fracture can be classified to complete and incomplete fractures. Incomplete fracture commonly in pediatric. So the plastic deformation or plastic bowing, there is no fracture line, only deformity and bowing of the bone. The buckling, also there is no fracture line, but there is a bruise, or there is like prominency at the cortex of the bone. And the green stick fracture, the fracture is only involving one side of the bone, and the cortex is intact on the other side. The complete fracture can be also divided to simple and comminuted fracture. So comminuted fracture is more than 3 fragments in the after the fracture. The simple fracture can be also described as transverse fracture or oblique fracture. The oblique is almost like more than 25 degrees to the axis of the bone, and then spiral fracture, and then also longitudinal fracture. It is like almost parallel to the axis of the bone. There are some different types of the fracture. There is no fracture line. These fractures are the impacted fracture, usually at cortical bone or metaphyseal bone, and depression fracture at the articular surface. So there is a depression at the joint surface, and compression fracture commonly in a very weak bone, especially an osteoporotic or even after traumatic at the spine. So the pathological fracture or stress fracture, the stress fracture also can happen in case of fatigue, stress, or after stress. So there are 2 types of stress fracture: the fatigue fracture or the insufficiency fracture. So the fatigue fracture, there is abnormal stress on normal bone. So there is a heavy stress, and the bone is failed or fatigue, and there they will develop fracture. For the insufficiency fracture, there is abnormal bone or normal stress on abnormal bone. So the bone is osteoporotic, and after normal exercising or normal activity, patient will develop fracture. So it's an insufficiency fracture, and the fracture result of the, if there is a tumor, if there is an infection at the bone, so there is a weak area, and patient will develop fracture. So what we call pathological fracture, as you can see here in this X-ray. There is some special classification to the fracture at the physis or epiphyseal area. So there are 5 types. Type 1, we call this Salter-Harris classification. So the fracture extending through the physis. This is type 1. The type 2 is extended through the physis and then through the metaphyseal part. When
This
the
is in
fracture
children,
extended,
صح دكتور?
this is in children, yes. This is Salter-Harris classification. So the type 3, it's a very common, by the way, common exam question. Like you might see an X-ray and you can, this is type 1 or type 2. It's very easy. When fracture extended to the joint, like epiphysis from the through the physis and then epiphysis, this is type 3. And if the fracture extended through the metaphyseal part, through the physis and then epiphysis, this is type 4. Type 5, when there is a distracted physis. There is no physis at all due to the trauma. It's almost distracted. So this is type 5. In order to describe the fracture, especially in simple fracture, you need to comment on the alignment, displacement of the fragment. In general, you can mention the alignment or displacement according to the distal, always according to the distal segment. So there is a medial displacement or lateral displacement, and there is a medial or lateral angulation, and the rotation, either internally or externally rotation, and there is a shortening or distraction at the fracture site. So it's a better also to mention how is the alignment or angulation or even rotation, shortening or distraction at the fracture site. So also in order to describe or classify the fracture, you need to know the type as we mentioned. Is it complete or incomplete, simple, comminuted? Is it compressed, depressed? So you can describe the fracture if in case of comminution, how highly comminuted. Is it mildly comminuted or severely comminuted? Location and anatomical location, like is it right, left, proximal, midshaft, distal, intra-articular, and also need to mention if it's open. If there is a break in the soft tissue, skin is open, you need to say this is an open fracture. So this is the, as you mentioned, the type of fracture again, uh, the simple, spiral, or segmented fracture. And the comminution, you can describe the comminution either with mild, not comminuted, mildly comminuted, or severely comminuted. Also the location of the comminution. Is it midshaft or metaphyseal area, distal end or proximal end? The translation medially, laterally, anteriorly, or posteriorly. And also you need to mention that like almost 50% translated laterally or medially, or 30% according to the width of your cortex. And the angulation also to the description, as we mentioned before, in respect to the apex of the angle or with the respect to the direction of distal fragment. So distal fragment is the one you can mention, is it the translation or angulation according to the movement of the distal segment. And also shortening. It's the amount of fracture collapsed, and we use centimeter or millimeter in case of description of the shortening. Sometimes they call it bi-unit opposition. So this, how can you mention the fracture, the comment on or the description of X-ray whenever you investigate for fractures. So in general, these signs and symptoms of fracture, usually there is the injury. In case of any injury, you need to know the mechanism of injury. Is it rotational? Is it bended forces? Is it axial? So you can expect what fracture is there. Is it spiral, transverse, butterfly, comminuted, or even compression in case of axial energy or trauma? So history is very important anywhere. Then most of the patients with fracture, they will come with pain, tenderness. They have difficulty in moving the joint or putting weight on the affected part. There will be a swelling or bruising at the trauma site. There might be a deformity or even abnormal movement due to the fracture. Like in fracture, it might move, so there will be abnormal motion. And then could be associated with wound. And in some situation, patient might be presented with shock. In case of femur fracture, patient can lose up to 1.5 liters of blood. What about if it's bilateral femur fracture? It means that patient he might lose more than 2.5 to 3 liters. So patient might be presented with shock. So you should be careful in treatment of those patients. So after we finish from the fracture, the dislocations. The dislocation is a separation of two bones where they meet at the joint. A dislocated bone is no longer in its position, might be associated with periarticular fracture. It's different from the subluxation. The subluxation is incomplete or partial dislocation. So again, the description of the joint dislocation, you need to know the joint and comment on the direction of the dislocation up on the distal fragment, like we learned from description in fractures. And you can add fracture if there is association of fracture, and also open in case of soft tissue injury. So there is a subluxation, like for example, proximal interphalangeal joint subluxation or posterior elbow dislocation. Shoulder dislocation, like it's a common in the anterior direction, and for elbow commonly in posterior direction, and most of the fracture or dislocation can be associated with either neurological injury or vascular injury. You see here the distal end of the joint, or the distal fragment of the joint, like in elbow, it's a posteriorly located, so it's posterior dislocation. Also in the hip joint is a common, almost more than 90% posteriorly dislocated. This is the common position of the posterior hip dislocation. Shortening, internal rotation. So please remember this, posterior hip dislocation position. Patient might be in internal rotation, shortening, and adduction. So that's the common deformity of lower limb in case of posterior hip dislocation. Remember this, might be a common MCQ question. So you can see here, the femur is adducted and migrated up. It means it's shortening, and also internal rotated. So the lesser trochanter is hidden behind the femur. Again, knee dislocation, you comment on the distal end of the joint. You see here the X-ray, it's anteriorly dislocated knee. And knee dislocation is very critical. It's associated with almost 30% of popliteal artery injury, and also up to even 30% associated nerve injury, like peroneal injury or common peroneal injury. If you heard knee dislocation, please, the most important thing is to rule out associated neurovascular injury. You see, we have seen patients with like below or above knee amputation due to missed vascular injury in knee dislocation. So be careful with this one. Also, this is a common question. It's not a common, but very fatal mistake if you missed evaluation of vascular injury in knee dislocation. Again, this is an X-ray of dislocated knee. This is anterior knee dislocation. Also, you need to rule out if there is any associated fracture at the knee or at the joint dislocation. Sprain is a joint injury that stretch or steers a ligament. So ligament can be injured. We call it, as you mentioned before, sprain. The ligament is the fibrous connective tissue that joins the end of one bone with another at the joint area. So now we know how to describe fractures, how to describe dislocation, or even soft tissue injury like in joint sprains. The fracture as a result of trauma or injury. So we know that the trauma are the leading cause of death in the first 4 decades. At the United States, there are more than 150,000 deaths annually. Permanent disability are three times more than the mortality rate, and it's very costly in case of taking care of traumatized patients. If you're transferring a patient from the scene, you need to notify the hospital about transferring an injured patient. You need to bring him to the closest appropriate facility and to report the pertinent information. In hospital, patients need to have prepared people in the emergency need to be buried with a warmed IV solution, and to notify the ancillary department like the blood bank if they might need blood transfusion, X-ray department, lab, and all the equipment should be ready, and also the personnel should be ready and protect their self. If you are hand-overing a traumatized patient to another medical personnel at the hospital, you need to mention the mechanism of injury, injury sustained or suspected to that patient. Need to tell the signs and vital signs to the other receiving personnel, and that treatment that initiated during transfer. So the most important for you guys is to know how to help patient with high energy injury. Always follow ITLS protocol. Preparation and triage, this is a very first step and very fast step, and the most important is the primary survey. Primary survey, that's the point that you pick up the very the most important cause of death. So you need to save the patient life. According to your primary survey, you need to start with airway, breathing, circulation, deformity or disability, and exposure. So A, B, C, D, E. So these, the primary survey, you need to check the airway and protect the cervical spine whenever you move the head in order to check the airway. You need to maintain the alignment of the cervical spine. So it's not only airway, it's A, C spine. And then B is the breathing and ventilation. Make sure the patient is breathing. And if you need to go ahead and put like intubation or any breathing help to let the patient to breathe. There might be a foreign body in the airway, so you need to clear the airway. And also make sure about the circulation of the patient. Make sure there is no hemorrhage, and if there is a hemorrhage, need to be controlled. And then look for disability or if there is neurological injury, and check how is the neurological status, and expose the patient with environment control, so prevent hypothermia of the injured patient. So this is a very important slide to know. And then you can go for adjunct to primary survey. In order, a patient need ECG, need chest X-ray or cervical spine X-ray, need even ultrasound to the abdomen. So this is the most important and where you can save the life. Secondary survey, it's a history and examination. So you need to know the ample history, which is the allergy, medication, past medical history, last meal if the patient going to surgery. So you need to know last meal, is it like before how many hours, and the event or the scene that trauma happened in. And then head to toe examination. That's where you can pick up most of the fractures, not a very severe fracture like pelvic, like you can pick up like metacarpal, metatarsal bone, ankle fracture at the secondary survey. Primary survey is the most important where you can save the patient life. Here you can pick up small or minor injuries. That's why you need to do a head to toe examination. And also at this stage, you can check for X-ray of the affected limbs, do lab works. If you need CT scan, you can order it, or the fast exam to check if there is any intra-abdominal bleeding or injury. There is some special group, which is the pediatric group. They have the same priority with different amount of fluid and different size of